Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So we're actually going to be talking about coding today. I know on the CodeCast I usually have a question that I like to respond to, which always has to do with coding. And then I do veer off sometimes into published guidance, Medicare regulation, compliance. And we do talk about coding. Obviously, we have to if it's the CodeCast podcast. But I really wanted to focus on coding today, and I wanted to focus on heart caths. Haven't really talked about it in a long time. It's my number one specialty. So for anyone that is thinking of either changing specialties or has a hard time with understanding cardiology or even just the basics of cardiac caths, I thought I'd give just some insight there without making this, I don't want this to be a webinar on that. I just want to have a conversation with you on some of the things to look for within your reports. If you're coding from a report, hopefully you are, or if you're getting information from your provider and you're not really sure what you're looking at, then hopefully I'll be able to just give you some insight there. So when we look at cardiac cath, first the definition, it's a procedure used to diagnose and treat cardiovascular conditions. So during a cath procedure, or cardiac catheterization procedure, you're going to hear me shorten that word to cath. A long, thin tube, and that's the catheter, is inserted into an artery or vein. It used to be, and I mean probably before the last 6 years, it used to be access in the groin or femoral artery area, or the brachial, which was the arm. But now we're seeing radial approaches, which is in the arm but wrist area, because you can get the patient up walking or ambulatory sooner. And then they thread this through the blood vessels into the heart. And using this catheter, then the doctor can diagnose, what's going on with that patient to treat possibly disease or blockages or, any kind of sclerosis problems that they're having that to open up that artery, vein, or vessel. So the patient is typically awake or lucid during the procedure. They're given some medications like maybe Versed, which is also a generic midazolam, Benadryl, and we call that moderate sedation. You can code for that as well, as long as you have at least documented. It's 15 minutes, but if you have at least 10 minutes, you've met the 15-minute threshold. And you can't just say at least 15 minutes was, or greater than 15 minutes. Don't say that. Your physician has to have in the report the exact amount of time that was used, that they were under their supervision monitoring that patient for the sedation, even if it was a hospital nurse, to be able to bill for the 99152, and you only get it once when you provide this cath in the facility setting, because there's no work value on anything extra under the place of service that's not 11. Then you really just want to make sure you have that in the report. Remember, the hospital or the facility is going to bill theirs, and your physician has to have in the report what they did in your actual op report. They can refer to the nurse's report after the fact, but they have to put under my direct supervision what they used, medication, and then how much time. And this just helps the patient relax, and there is actually a very low risk of complication with cardiac cath. And so if there is a heart problem, then, or even a heart attack, if there's a suspected problem of a blockage, then that's when the patient is then forwarded, or there's a conversation about the patient then having a intervention, which means we're going to open up that vessel. I'm sure you've heard of stents and angioplasties and atherectomies, etc. We're not going to talk about those today. I just want to talk about the diagnostic portion. Now, one thing you do need to know when it comes to cardiac cath is that there is adult medicine, and then, which is congenital information, and then there is okay, I just got a stray dog moment here. I'm sitting here, I'm going to keep this on the podcast. I'm recording and I'm looking out my window, and two squirrels just stole an orange off a tree and ran with it. So I said the wrong thing. So I apologize for that, but I'm watching these two squirrels with oranges in their mouths. Sorry, stray squirrel moment. And I'll get back to this. So congenital is treating children, the pediatric side, and then you have adult medicine side. So if you see anything that's talking about congenital medicine or anything like that, then they have a separate set of codes, and you'd have to just look at those codes specifically. But when we talk about adult medicine, so congenital would be the 93452 codes to 93461 codes. We're looking at adult medicine, which starts when we are looking at the 93451 to 9345. Let me see how far I'm going to go with this. Really 93461, and then there's some add-on codes and things like that. But again, I'm just having a conversation. This is not a webinar on this. Sorry for my stray squirrel moment. Hopefully you'll find that amusing since it is a podcast and not a webinar. But the other thing you want to look at is there's some inconsistencies when people code for these services, because you can be confused of what you're looking for. And the most routine heart cath is the 93458, and you put a 26 modifier on it. This means you're crossing over the aortic valve. You're going into the heart. You may be injecting, they call that a left ventriculography, LV gram, an injection into the left ventricle. Or you could just be measuring pressures, and you can't get those pressures unless you go into the heart. That's why you still get to keep the 93458. If you find something in the report, and this is something you could probably at some point replay and write down, you're looking for the acronym LVEDP. And what that is left ventricular end diastolic pressures. So when there's no injection into the left ventricular or left ventricle, and so there's no LV gram, they call it, performed, then you can support crossing over the aortic valve or going into the heart if your angiographic data or results give you pressures of that LVEDP, or it might just say LV ED, or it might just say LED. So just know that you're looking for left ventricular end diastolic pressures. So you're measuring the hemodynamics, or how stable the patient is, or what's going on in that heart area, and you could still have that. The other code that everyone wants to code all the time is 93454, again, 26 modifier. Now this means you stopped short of the heart. You only injected the coronary arteries, right and or left. It could be one or the other or both, but you didn't actually cross over the valve and go into the left ventricle, go into the heart to measure those pressures. And sometimes this is being coded incorrectly. So if you have one physician who just did the heart cath, the full complete heart cath, 93458, and transferred the care to the interventionalist, who will then probably re-inject just to see what they're looking at on the films from the previous heart cath, you can't code for that. You can't code the 93454 because it's no longer what we call diagnostic. So it's just basically setup angiography. And it's pretty clear in the CPT book that it says you can't code it for contrast injections or to roadmap, so to measure what you need for that stent, anything like that. It can only be if you're still trying to find a problem. So keep that in mind. Anytime you're providing services under the catheterization side. Okay, now they're fighting over the orange. I'm sorry. It's just funny to me. When you look out the window, it's just funny. I'll try not to look out the window, but it's funny to me, fighting over an orange, two squirrels. Anyway, I seriously don't have ADD, but today I'm just laughing because it was just the funniest thing I've ever seen. Anyway, so when you get into that 93454, an example of when you could code for it is, let's say you had a patient at a previous left heart cath, so the full-blown 93458 on the 7th of January. There was limited disease. The doctor decided not to proceed with intervention, sent the patient home, but the patient the next day had recurrent chest pain. They had shortness of breath. There was a definite concern. They had high troponin levels. The physician brings the patient back to the cath lab, injects in the right and left coronaries, and said, okay, we found the occlusion in the right coronary in the distal artery, and we're going to go ahead and put in a stent later that day or at the same time. Then you could code for it, because remember, you're still looking for something. You're figuring out why are they having a recurrence of those symptoms. But if you did the heart cath, let's say on the 7th, and transferred the patient that needed to have a stent that day, you transferred to the interventionalist, and they did a re-injection, then no, you can't code for it. So think of this as kind of like an EKG, where the patient had, let's say they were in the office and had a new patient visit, EKG. There was definitely some changes. It was inconclusive, but the doctor said, you know what, we're going to go ahead and do a treadmill just because we want to make sure what's going on. They bring the patient back in, they do an EKG as a baseline before they do the treadmill. You can't code for that. So, but if your doctor saw an abnormal EKG on the same day as a new patient, said, "Oh, take them over. Let's get that stress test right now because we may have to take them in for a cath," then you could code for it. So, a lot of cardiology has to do with intent, and that's just really important to understand the concept before you go all out and start billing for things. Just because you find it in the report, you also have to know why you did it. And cardiology is really big on that, especially if you get into EP, electrophysiology. There's a lot of things there where you have to say, well, first, what's the intent? Was it for AFib? Was it for ventricular tachycardia? What was it for before we know how we can code? Same thing when it comes to heart caths interventions, that you can't code for it until you know why you're doing it. What's the intent? Is it diagnostic? Is it for setup? Is it just because you're there? That's something that you have to be very careful of. So the CodeCast podcast is also brought to you today by Decision Health. Join Decision Health this November for the Advanced Specialty Coding Virtual Summits. Dive into orthopedics, pain management, and anesthesia specialties and get the latest guidance for accurate coding, billing, and compliance. Visit codebooks.com/events to register. Save $50 with coupon code ASC2024. So as I'm getting back to the cardiology side of this, I just want to say a couple other things. Make sure that you're looking at the full and complete definition of heart cath so that you know, let's say your physician added a graft injection, or let's say they looked at, and it's not the right coronary, they looked at the right side of the heart and the left side of the heart. Remember, the right and left coronary are on the left side of the heart. The right side of the heart now has pulmonary and venous or vein intervention. And they're looking at possibly pulmonary hypertension. So some people get that confused. Well, they did a right and left coronary, so that's a right and left heart cath. No, it's not. Right and left coronary stays with the left heart cath, but the right side of the heart and the left side of the heart, now you're at right and left. And there's combined codes for these services. Sometimes there might be an extra code to add an injection if it's not part of the descriptor. But you need to understand really what's in the descriptor before you start kind of spitting out codes. I also have several on-demand webinars for cardiology, so please take a look at my website at terryfletcher.net so that we can, make sure that you get what you need from an educational standpoint. And all of my heart cath and cardiology webinars include the interventions as well. I also wanted to shout out some new Coding Corner clients. We've had a flood of new memberships, especially executive memberships. And for those of you that don't know what that is, this is an online question and answer system. So if you have questions about any specialty that we cover, look at our website at terryfletcher.net. You can see what specialties we cover, and you send us an email and we answer your question within 24 hours. We can help you with, coding if you need it. We can help you with appeals and just getting that regulatory guidance cited works in case your physician says, well, I want to do this, and you're saying you can't do that, but they said, why not? And you just say, well, hold on that thought, send me an email, and then you know. So we have a paid membership service, and we just appreciate it. We've got some physician clinics of Iowa, we've got some Power Health Indiana, we've got Hattiesburg in clinic in Mississippi, and we've got some Midwestern University in Arizona, and then we have some of our new clients also in Southern California. So we appreciate all of you. We really love having our memberships. Also, if you're an executive member, you get an Ask Me Anything call every quarter, and that's on Zoom, and we all whoever's on the executive membership, you get together and you can lurk and just listen, or if you have questions you want to ask live, you can ask them. So anyway, enough of that commercial message. Just want to let you know that was available. So I have another coding question I wanted to cover today, just real quick. This one was an interesting question because I had to really think about this, and then it came up in an audit I did for Medicare, and I really appreciated my CMS insight on this because he was like, okay, let me explain how this works. So you'll notice on a lot of grids for the E&M levels of service on the data element, so the second element of being able to support a level of service, on level 2 it says minimal or none. So I've had providers say, well, if I have a minor problem and I do absolutely nothing on data, then I can have a level 2. So you can say somebody has a big nose and then basically do nothing and do nothing on the management, and they said I can have it. No. So here's the intent of that. remember it says minimal or none. So what it means, and this is CMS saying this, is that if you consider that let's say the patient comes in again with that big nose and there's a mark on it, and they say, oh, that's nothing, and they just let you go. There is nothing. But let's say they think there's maybe something there that they have to do an x-ray, or they have to do, maybe a biopsy, or they have to maybe take a look closer and do maybe a scraping to send to pathology or something like that, just to make sure there's not a problem. If they consider it and the patient says, no, let's not do it. If you think it's okay and the doctor says, I really am not concerned with it, we can do this, this test if you think if you're worried, but right now I just want to keep an eye on it, and that's well documented, that's where the minimal or none comes from. It means it was considered. So they also have the same concept when it comes to considering certain management options. Patients decided that they're not going to have surgery right now, but the physician actually pushed for it, and you still get credit for that surgery management risk option. But in data, it's the same thing. You have to document what that consideration was. The patient can't just come in for something that is nothing, and then because the data says minimal or none, that if you're using the none saying, oh, well, we didn't do anything, so we can just have patients come in for nothing. No, that's not how that works. So and how it was explained to me is that they wouldn't have put that as minimal or none on the same line if they said that you could do nothing. It means minimal or none, that you considered something basic, maybe just one test or one external, lab or something, one thing you ordered. And remember, you have to have at least combination of two to get to even low. So if you just had one and you decided whether you're going to do it or not, or as a point of care test, or you just didn't do it, and it was documented that maybe you wanted to or you considered it, then that is where the none comes in, where you considered it but just didn't do it. So keep that in mind, just try not to give credit where credit isn't due. Okay, so it has to be documented that there was something there. Okay, well, hopefully you found this information helpful today. I know sometimes I get away from actual coding because I really like the CodeCast to be all about coding, billing, compliance, learning everything, and not just, we're going to code today. So hopefully you did find that helpful. What little bit of a tidbit as far as a personal note. So football season's up. I'm so happy, except the first preseason game, the Steelers were terrible. I won't say they sucked. Okay, yes, I will. Yeah, they were terrible. So but we didn't have our starting quarterback, which is supposed to be Russell Wilson. I miss Kenny Pickett. He's now a backup over in Philly, and he did well. Of course he did. But our backup, Justin Fields, did terrible. So did our I'm air quoting starters, because it was not good. Let's just say it was not good. I was like, okay, let's change the baseball now. But anyway, let's hope they clean it up, or I hope they clean it up. And so we go into the season hopeful, and not just say, oh, we had another non-losing season at, whatever that would be. So anyway, I'm excited. We're getting back to football. Hopefully it'll get cooler soon. And I hope everyone is enjoying the rest of their summer before everyone gets back to school, gets back to normal routines at home. And don't forget, that means traffic is going to increase soon. So get out and do what you need to do before everyone gets back to, what their routines are from the fall season. All right, everyone, make it a great day. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.